I am Dr. Karli Gitanjali from Ayush department, and today we are here to discuss liver diseases. First case is liver cirrhosis, and for that we have PG scholar from Ayurved Seva Sangha College, Nashik, Dr. Anshul Deshmukh. He is second year PG scholar. Then our experts, today we have Dr. Pratibha Sonone. She is Associate Professor, Department of Medicine from MPGI Medical College, Nashik. Then second expert is Dr. Sanjeevani Rathod. She is HOD and Associate Professor from Department of Kal Chikitsa Ayurved Seva Sangha College, Nashik. Then third expert from homeopath is Dr. Kamlesh Bagmar. He is Assistant Professor from Department of Motiwala Homeopathic College, Nashik. Welcome to all. Let's start from Dr. Anshul. Anshul, you may share your screen.
Thank you, ma'am. Good evening to all of you. Myself, Anshul Deshmukh. I'm a PG scholar. Ma'am, I'm a first year student, surgery department from Ayurved Seva Sangha College, Panchvati, Nashik. So, today's my topic is liver cirrhosis. Is one of the chronic liver disease. So, I will be presenting the topic now, PPT. So, there was a patient, Mr. ABC. He was a 43-year-old male, and he was a daily laborer. He was admitted in our college, in our hospital on 2nd of February 2025, and the date of examination was 5th of February. The present complaint of the patient were distension of the abdomen since the 1 month. He has also difficulty in breathing from 2 weeks, as well as the swelling of the both the legs from 10 days. Actually, these complaints were also present 6 months ago back. I have mentioned in the next PPT. He was on medication in between. So he was on diuretics and spironolactone in between the period. From 1 month, these symptoms were worsened. So he was not actually asymptomatic. He was on episode. He has an episode of 6 months back, and he was on medication. Um, After that, he had taken spironolactones, furosemides, and some beta blockers, propranolol. And after that, he didn't get relief. The condition worsens before 1 month. So it shows the chronicity of the disease from 1 month. The symptoms were worsening. So this is acute on chronic liver disease. This is actually not a chronic liver disease. It's acute on chronic liver disease. It is chronic liver disease with acute decompensation. So presenting complaints, there was abdominal distension. Actually, the distension was due to the fluid, because there is the patient has given the history of paracentesis. I have mentioned in the next PPT, next slide. But before that, I will mention some points. The distension was generalized distension, so it indicates the fluid. Shifting dullness was also present. The dull sound was also present, and distension changes with the position of the patient. So it indicates that the distension is only due to the fluid. Otherwise, the other causes of distension are fluid, fat, flatus, feces, fullness of bladder. In case of female, it is due to the fetus. So fluid and fat are the reason which produces the generalized distension. Uh, After that, I would like to mention the point that the distension was gradual. That is, the ascites of the patient was gradual. It was not rapid. Because in case of rapid distension, if the distension was rapid, it could be due to Budd-Chiari syndrome, acute pancreatitis, or acute peritonitis. But patient gave a history of gradual increase in the abdominal distension. So the patient was asymptomatic before 1 month back, and he notices the distension of abdomen with pants becoming tightening over the abdomen, which was insidious in onset. The distension was gradually progressive. There was no aggravation or relieving factor. Since 2 weeks, he was experiencing difficulty in breathing on lying down position, that is orthopnea, because pressure of the fluid on the diaphragm, which reduces the vital capacity of the lungs. Generally, orthopnea and ascites suggest the gross ascites. Uh, okay. However, he could sleep in the semi-recommended position. There is history of swelling of both the feet for 10 days. Hello. There was swelling of both the feet from 10 days, was incidence on onset, gradually progressive, limiting up to the ankle. No diurnal variations relieved on taking the medications. I would like to mention some points that swelling on the both feet. There are many causes that can be due to the liver disease, heart failure, kidney disease, venous insufficiency, or some nutritional causes like hyperproteinemia. But ascites, along with the bipedal edema, it is an ascites which is non-painful. It is mostly in causes related to liver. If the patient did not have pain and later started the pain in the abdomen, it can be due to spontaneous bacterial peritonitis. But my patient does not have such kind of symptoms. He was painless, generalized distension of the abdomen along with the bipedal edema. Later that I have taken some negative history to rule out some points. There was no history of fever. If to rule out what we call spontaneous bacterial peritonitis, vomiting as well as diarrhea. There was no issue of breathlessness, wheezing, chest pain, cough, or expectoration. As my patient is chronic smoker, to rule out some COPD causes.
Hello.
So I have taken the history of breathlessness, wheezing, chest pain, and cough.
Hi.
There is no there is no history of vomiting of blood and passing of black color stool. To see any bleeding disorders present in him or not. There was no history of yellowish discoloration of eye or micturition. Presently, he is not suffering from jaundice, as there is no history of irrelevant talk or involuntary jerky movements he has. So there is no history of bleeding tendencies. I have taken these histories to rule out some points like to rule out hepatitis, pancreatitis, and peritonitis as pain along with the ascites in the abdomen. It is only
Hello.
present in hepatitis, pancreatitis, and peritonitis. As fever to rule out SBP, spontaneous bacterial peritonitis. I had taken the respiratory history of breathlessness, wheezing, chest pain, and cough expectorations to rule out COPD. If the COPD was present with ascites and pedal edema, then it could be the right heart failure called as core pulmonary. So the diseases are ruled out according to the questioning which I was asking him. Vomiting of blood is due to the hypertension, gastritis, or ulcer. To rule out gastritis and ulcer. After that, I have taken their discoloration history, that is other discoloration of iron micturition. That is the once there is cirrhosis of the liver, there is regenerative nodules, and jaundice is not so common with chronic liver diseases. Jaundice actually present with mostly with acute liver diseases, not with the chronic liver diseases, unless there is superadded hepatitis or there is space occupying lesions in the liver. So after that, I have taken the history of irrelevant talk or involuntary jerky movements. The patient was not with the symptoms to rule out hepatic encephalopathy. And at the end, I have taken the history of bleeding tendencies to rule out the clotting factors, clotting factor deficiency, platelet deficiency, dysfibrinogenemia, or increase in salicylic acid. After that, history of past illness. So there is similar history 6 months back. The patient can't actually recall, but he has the same complaint 6 months ago, and he told me about that paracentesis were done. That is 4 liters of fluid were removed from the abdomen. There was no history of hypertension, DM, tuberculosis, or any other chronic diseases. So in his personal history, we found that the patient was ethanolic since 25 years, and he has consuming country liquor of 4 glasses. Actually, the significant alcohol consumption level for women is three drinks, and for male it is 4 drinks. In a standard variation, we tell that one drink means 12 ounces of beer. One drink means 5 ounces of wine, and one drink means 1.5 ounces of spirit. So my patient was significantly alcoholic, and he was also a chronic smoker since 25 years. These are the main causes of his chronic liver diseases. Uh, I called him alcoholic on the basis of cage criteria. Now, C means what we call have he get cut down, or have he get annoyed, guilty, or eye opener. According to cage criteria, I called him alcoholic. And smoking has a direct effect on fatty liver diseases. So these two main are the main causes. Hello, ma'am. Okay. Uh, uh, I had taken the history of tattooing or IV drug abuse because to rule out viral hepatitis or drug or toxicity. Okay. Uh, family history. There was 6 member in his family, and some liver diseases runs through the family. So he has no such history like alpha 1 antitrypsin deficiency, hemochromatosis, or Wilson's disease. So the patient has no such kind of family history. Uh, After that, general physical examination was done. I would like to summarize my history once again. The young
Anshul,
middle-aged patient. Yes,
can
ma'am.
you zoom your slides?
Oh, sure, ma'am. Is it visible, ma'am?
Okay, but okay.
Okay, ma'am.
Yes.
Before going further, I would like to summarize my whole history taking. It is a young middle-aged male who is non-diabetic, non-hypertensive, consume alcohol and smokes, significantly smoking history from so many years. Now has come with progressive abdominal distension from last 6 months, which has worsened over the past 1 month. So provisional diagnosis is CLD, possibly due to the chronic alcohol consumption, and the presentation is acute on chronic liver disease. Uh, there are some situations. There can be some situations where the patient get complications of cirrhosis, like uh, there are some situations where the patient can get acute complaints from 1 month, that is non-compliance of the medication. The patient continued his alcohol consumptions. Now, because of these two reasons, the patient did not get relief, and the symptoms get worsened over the period of time. It could be due to SPP or hepatocellular carcinoma, may develop renal failure, or may develop a heart failure. But main two reasons are non-compliance of the medications and continuation of the alcohol consumption. So I had taken general examination. Patient is awake, conscious, and cooperative, well-oriented to time and place and person. That means hepatic encephalopathy is ruled out. He is moderately built and undernourished. BMI was 17.5 kg per meter square. Pulse was 86, regular rhythm and normal in volume
काय
carried.
प्रश्न विचारायचा तुम्ही काय प्रश्न विचारणार
BP was 100 by 80 mm for Hg. Respiratory rate was normal, 22 cycles per minute, and the temperature was 97.6 degree Fahrenheit. That means he is febrile. Here, hypovolemia may be due to the drug or it may be due to the sepsis. Mm, On general physical examination, the pallor was present, no icterus, cyanosis or clubbing or lymphadenopathies. Nail shows leukoncia. Leukoncia is the symptom present in liver cirrhosis. There is white spot or streaks on fingernails. Colincia, spoon-shaped nails. Mild pitting edema found over the feet and lower third of the leg. There is gynecomastia present, which is non-tender. Gynecomastia is also a sign of symptom of liver cirrhosis. There is no spider navy. Dupuytren contracture was present. Dupuytren contraction is a sign of chronic alcoholism, smoking, or it found also in diabetic patient. So Dupuytren contraction was present, and palmar erythema was also present. No parotid swelling, no flapping tremor, or altered consciousness. On inspection, there is generalized distension of the abdomen with maximum fullness of the flank in supine position. The abdomen moves with respiration, no abnormal pulsation were found. Umbilical is even aorted and centrally placed. No scars, stria, or dilated veins. All the hernia orifices were normal, and diverticulosis recti were present, and spine is normal. After that, on palpation, superficial palpation, there was no rise in temperature or no tenderness. Testicular palpation, testicular atrophy with reduced sensation present. Testicular atrophy is also a symptom of liver cirrhosis. Deep palpation, abdomen was soft. On palpation by dipping method, liver is non-palpable under the right costal margin, and spleen is somewhat enlarged, 4 centimeter from the left costal margin, moves with the respiration. These are the measurements which were taken at the time. On percussion, liver dullness, upper border was present on fifth intercostal space and lower border at the costal margin of the right side. Liver span was 30 centimeter, shifted dullness was absent, and fluid thrill was present. Shifting dullness actually was absent due to the tense ascites. It is absent due to the minimal ascites or loculated ascites. But in this patient, the shifting dullness was absent due to tense ascites. On auscultation, normal bowel sound was heard. No venous hum. Sorry, this is spelling mistake. No venous hum, HUM. No arterial bruits. No hepatic and splenic rub. Other system examinations were normal. CVS, cardiovascular system was normal. Central nervous system was normal, and respiratory system was normal. These are the differential diagnosis done on chronic hepatitis, alcohol liver disease, non-alcoholic fatty liver, and so on. These are the 13 differential diagnosis. Rather than we'd done some investigations, there we done LFT, CBC, USG. In LFT, we mostly found albumin is a marker of chronicity. So low albumin indicates the CLD. Low level of albumin indicates the chronic liver disease. Viral markers were also done to rule out hepatitis B and C. LFT was done. CBC was done. In CBC, anemia, thrombocytopenia, or pancytopenia can be there, as well as serum urea, serum creatinine, serum electrolyte were also done to rule out hepatorenal syndrome. Uh, in upper GI endoscopy to look for varices. We also done upper GI endoscopy to look for varices if present. Uh, Ascitic tap was also done to serum to albumin ascitic gradient. Based on that, if it was present on 1.5 or 1.1 greater than 1.1, it could be portal hypertension. If less than 1.1, it could be pancreatitis or abdominal tuberculosis. In our patient, it was greater than 1.1, so it is due to the portal hypertension. Sodium, potassium, these were also done. Chest X-ray was done to rule out hepatocellular carcinoma. Alpha ketoproteins were checked. Triple phosphate CT abdomen was also done. In USG abdomen, we found out the USG abdomen suggestive of cirrhosis of the liver with moderate ascites and splenomegaly. ECG shows normal cardiacpathy. There was no cardiac encephalopathy present. So this is all. Thank you so much.
Thank you so much, Anshu.
Thank you so much, ma'am.
Thank you, sir. Thank you.
Thank you so much. Now please stop your computer department, please take care of noise. And participants, please mute yourself. You are disturbing all. Anshul, please stop your sharing.
Yeah. That's all, ma'am. On the basis of this history taking and his investigation,
Yeah.
we have found that the patient is suggestive of cirrhosis of the liver.
Sharing, screen sharing. We will go to expert opinion from Dr. Pratibha Sonone ma'am. Pratibha Sonone ma'am. She is associate professor from MPGI College of Nashik. She is gastroenterologist, and today she will deliver her expert opinion about modern medicine regarding liver cirrhosis. So, ma'am.
Yes. Hello, everyone.
Hi, ma'am.
First, I will like to say very nice case presentation. He has given very good logical reasoning of all the history he has taken. Okay. Only a few points I will like to mention just to improve him. That whenever there is a gross ascites, you cannot comment on the liver span because you already the abdomen is dull. So it is very difficult to know the lower margin of the liver. So in exam, for exam purpose, I am telling the resident that don't mention this liver span if your patient has very gross ascites. In your examination finding, you told that there is no shifting dullness, fluid thrill is present. That means there is a tense ascites. Okay. So never mention about the liver span. Second important thing is you should not mention about the BMI because this patient is in fluid overload. You know that the weight is not the actual weight of the patient. It is because of the ascites and the edema fit he is having. So again, you cannot comment on the BMI of the patient. Instead, you should actually comment on the nutritional status patient. Like as you mentioned, it was around 17. That means patient has severe sarcopenia and loss of buccal pad of fat. There is a thinning of the palm muscles. All these malnutritional things should come in examination finding. Okay. Now we will go to the discussion. I will share the slides. Okay. So can you see my slides?
Yes, ma'am. Your slides are visible.
Okay. So first, what is liver cirrhosis? Liver cirrhosis is basically when the liver parenchyma is replaced by the scar tissue. When the normal healthy liver hepatocyte is replaced by the inflammatory tissue or a fibrous tissue. So that will lead to the cirrhosis of the liver. As you can see in the picture, there are healthy multiple hepatocytes in the liver, in a healthy liver. Whereas in a patient of cirrhosis, you can see only few hepatocytes are present, and most of the liver parenchyma is actually replaced by the damaged tissue, which is actually a scar tissue. So we have very few hepatocytes which are actually functioning in patients of liver cirrhosis, and it is an irreversible damage to the liver. So that is a basic thing about the liver cirrhosis. And then we will discuss about various causes. Now, most important cause in our country is alcoholic liver disease. Second comes non-alcoholic fatty liver disease, that is NFLD, which is on the rise. Chronic hepatitis B and C are the treatable causes of liver cirrhosis. Now, because of the availability of the antiviral drug, the percentage of patients of these patients who present with viral hepatitis and liver cirrhosis are now declining, whereas alcoholic and fatty liver related NFLD liver cirrhosis, they are on the rise. Then there are some other rare causes like autoimmune hepatitis, primary biliary cirrhosis, secondary biliary cirrhosis because of the chronic obstruction of the bile duct, primary sclerosing cholangitis, hemochromatosis, and autoimmune diseases. Then metabolic diseases like Wilson's, alpha-1 antitrypsin deficiency, and the list goes on. But remember, the most important causes are alcohol, NFLD, viral hepatitis, and then comes the other. And also don't forget to rule out this venous outflow obstruction, that is Budd-Chiari syndrome, and cardiac cirrhosis, which can be missed. Okay. So now coming to the stages of the liver damage. Initially, the liver is healthy. Then comes the stage of a fatty liver. Whenever, because of the alcohol, NFLD, or even with viral hepatitis, initially there will be accumulation of the fat inside the hepatocytes. Because of that, the size of the liver increases. So patients will have hepatomegaly at this stage. Patient may sometimes complain of a right hypochondriac pain, or they may be asymptomatic. Then is a liver fibrosis. So whenever the etiological factor continues, like patient continues to have alcohol, or patient continues to have repeated episodes of autoimmune hepatitis, finally, because of the consistent inflammation going on in the liver, there will be a fibrosis. And this will lead to the irreversible damage to the liver, and we will land up in the liver cirrhosis. Okay. So this pathophysiology is described here in the next slide, where there is a chronic injury to the liver because of any etiological factor which we have discussed. That will lead to the consistent inflammatory damage to the liver. That leads to the progression to the fibrosis, and then there will be disruption of the normal liver architecture and loss of the liver functions, which will ultimately results in the symptom of the patients. Some patients may even develop hepatocellular carcinoma. Now, this progression from normal liver to liver cirrhosis may take place over a period of 5 years to 50 years. Okay, this is variable in every patient because there are many other factors which also contributes to the progression of this liver cirrhosis. Now, most important is the genetic polymorphism, because of which you can see that some alcoholics, they have a history of 5 years, still they will have liver cirrhosis, whereas some patients who may have a 50 years history, but they may not have liver cirrhosis. They may just have a fatty liver. Okay. So there is some role of genetic polymorphism. There is a role of a nutrition, malnutrition, as well as obesity. Both will lead to the faster progression to the liver cirrhosis. So both the things are harmful. Okay. And if there are two etiological factors in one patient, like if patient is alcoholic and he is diabetic, that means he has NASH also. So they will have a rapid progression. So these are the factors which decides how long it will take to progress the liver cirrhosis. But in short, it is very variable. So you cannot predict the in given patient. Okay. Now coming to the diagnosis of liver cirrhosis. Initially, the blood workup is done, like we do a CBC. So CBC will show presence of thrombocytopenia because of the portal hypertension. Sometimes they may also have leukopenia and low hemoglobin levels. Anemia is seen in most of these patients. One, it may be because of the hypersplenism related to the portal hypertension. Second, it may be a nutritional anemia. Third, it could be an anemia related to the blood loss because of the varices, or sometimes even hemorrhoids are very common in these patients. So iron deficiency anemia is common. Alcoholics may have folic acid deficiency, so they may have a megaloblastic anemia. So these are the 4-5 things which contributes to the anemia in these patients. Then, so coming to the LFT, in liver function test, we can get usually we will have a normal bilirubin in the patients of a liver cirrhosis. They will have raised SGOT and SGPT. The ratio is important. If OT is more than PT, then it goes in favor of cirrhosis. If there is a SGPT is more than SGOT, then try to find out the causes of chronic hepatitis. It could be a chronic hepatitis. Okay. And if the bilirubin is raised and PT is more than OT, then it could be an acute viral hepatitis. So based on LFT, we could come to some conclusion about what the patient is having. Second, as mentioned by the resident, the albumin levels can be low because of the low synthetic functions of the liver. So the serum albumin will be low. Then we can do some additional investigations like creatinine is important because these patients are prone for hepatorenal syndromes and they are also prone for acute kidney injury. Many of these patients are taking diuretics, so their creat electrolytes can get deranged. So creat electrolyte is must in given patient. Then ascitic fluid examination, if patient has ascites, we need to calculate a SAG ratio, that is serum albumin minus ascitic fluid albumin, which is if more than 1.1, then defines the portal hypertension. Also, it will look after the presence or absence of SBP. If the absolute neutrophil count is more than 250 in ascitic fluid, then it is labeled as SBP. Even tuberculosis in our country is common in patients of liver cirrhosis because they have low immunity. They are prone to get tuberculosis infection. So even ascites may be because of tuberculosis. So ascitic fluid examination should be done in every patient who is admitted with first time ascites. Okay, or who has admitted with acute decompensation. Then alpha fetoprotein level, if we are suspecting the hepatocellular carcinoma or USG is showing any mass in the liver, then definitely alpha fetoprotein levels. Even sometimes we do a PUCA2, that is a marker for the hepatocellular carcinoma. Then some additional tests may be required depending on the patient's presentation. USG is useful to diagnose because it will show important features of liver cirrhosis. The features which are seen on USG are usually a small liver, nodular liver. So the normal clean liver parenchyma is replaced by an irregular nodularity, which can be detected on ultrasonography. Second, there will be features of portal hypertension. So we will get the dilated portal vein and presence of so many collaterals in the abdomen. Even the portal Doppler will be helpful to establish the presence of portal hypertension. It will show the reversal of the blood flow in the portal vein because of the portal hypertension. Now, the gold standard for diagnosis is always a liver biopsy, but because the diagnosis is usually made based on the history, examination, clinical finding, then the lab and USG. So usually we don't do a liver biopsy unless we are suspecting some rare cause like autoimmune hepatitis or Wilson's disease, then we go ahead for a liver biopsy. Otherwise, liver biopsy is not required. Okay. And if we are suspecting hepatocellular carcinoma, then we can do a liver biopsy. Otherwise, liver biopsy is not required. Nowadays, we have a very good investigation, that is FibroScan, which is like an ultrasonography, which can detect the liver stiffness. And it is really helpful in managing the patients of liver cirrhosis. We can get an idea of the degree of fibrosis in a given patient. And we can see on follow-up after treatment how the patient is improving. So we can do a repeat FibroScan. This FibroScan is a non-invasive procedure, so it can be done on an OPD basis, and it gives very important information about the status of the liver. Now going to the approach to the patient of liver cirrhosis. Actually, this topic is very vast and it is very difficult to cover in a short time. Still, I'm trying to cover the important points here. When we first detect that patient has liver cirrhosis, try to get search for the possible causes, like whether it is alcohol, diabetes, or patient is having chronic hepatitis. Then confirm the diagnosis by doing the lab test, ultrasonography, and elastography. Based on this, do the staging of the liver cirrhosis, which can be done based on a child score. The score has important components of bilirubin, albumin, ascites, encephalopathy. So these important points are noted, and then we can calculate the child score. And the patient is divided into A, B, and C stages. C is decompensated liver disease, A is a compensated liver cirrhosis, and B is the in between of the two. Okay, so this is important from the prognostic point of view. And then we have to start treatment based on the etiology as well as based on the complications. Okay, so treatment basically we have to do of the etiological factor. That is, if it is alcohol, then alcohol abstinence is important. If it is Hep B, you have to give antivirals. If it is hepatitis C, then the specific antiviral has to be given. If it is autoimmune hepatitis, we'll have to give steroids and azathioprine. If it is Wilson's disease, then we may have to give penicillamine and zinc. Okay. Then based on complication, we have to treat the patient. And the last option remains is the liver transplant. As I told you that this is an irreversible condition. If the patient is not improving with the best medical line of treatment, ultimately patient needs a liver transplant. Okay, so treatment we have discussed that treat the underlying cause. If patient is NFLD, then we have to ask the patient to reduce the weight, do regular exercise, and had a good blood sugar control. Okay, if it is other rare condition, then depending on the cause, we have to decide the treatment. For managing the complication, if it is ascites, that is accumulation of fluid in the abdomen, we have to give diuretics and a low sodium, high protein diet. Okay. If there are varices, then if the varices are large, we may require banding. If we add a beta blocker to them so as to reduce the risk of bleeding from the varices. If patient presents with hepatic encephalopathy, then we have to find out the cause of encephalopathy, like constipation may be there. So we have to give the lactulose enemas. If there is hypokalemia, we have to treat with potassium replacement and other medications for encephalopathy. Then based on the other complications, we have to treat. Like if patient has hepatorenal syndrome, we have to give IV albumin and terlipressin to the patient. If patient has jaundice, then find out the cause of jaundice and we may have to give the treatment accordingly. So the medications used in these patients of liver cirrhosis are mainly the diuretics, antiviral, beta blocker therapy, all the liver supportive medicines, nutritional therapy. So most of these patients will require correction of anemia. Vitamin deficiencies are very common, so you have to give multivitamin to them. Lifestyle changes are very, very important. A diet should be rich in protein. It should be low in sodium. Then patient should do regular physical activity if possible. If patient is decompensated cirrhosis, he may not be able to even walk. So depending on patient's physical condition, you have to advise him the lifestyle changes. And of course, they have to avoid all the medication who can worsen the liver damage, or all the hepatotoxic medicine should be avoided in these patients. So key points here are, if we do early detection, then we can avoid all these problems. So early treatment is crucial in slowing down the progression of cirrhosis, and we can prevent the complication. A multidisciplinary team approach is always helpful. So it is not only the hepatologist, but even the nutritionalist or even the critical care intensivist is involved in managing these patients. And simultaneously, you have to educate the patient, counsel the patient, and give support, because this is a long-standing disease. We have to improve his quality of life. We have to manage his symptoms as well as take into consideration so that patient can live longer happily. Okay. Thank you.
Thank you so much, Dr. Pratibha.
Yes.
Ma'am have explained everything about liver cirrhosis, detailed discussion about progression of disease, how to diagnose case, how to treat, and what are the causes of anemia and all. So thank you so much, ma'am. Next, to discuss Ayurveda aspect of liver cirrhosis, we have Dr. Sanjeevani Rathod. Ma'am, Dr. Sanjeevani Rathod. Yes, ma'am, please unmute yourself. Ma'am, please unmute yourself. You are not audible. Yeah. Ma'am, please start.
Yes, ma'am.
Yeah.
First of all, I congratulate Anshul. You have done very well. The case study is very well explained by you. And ma'am also elaborate the all things about the liver cirrhosis. Now I can explain the Ayurvedic aspects of liver cirrhosis. The first is underlying etiology. As per the etiology, which are the causes are responsible for the liver cirrhosis. The first of all main cause is the alcoholic. And as per alcoholic, the disease we have called as per Ayurveda, that is a Madatya. And the main cause is alcoholic. And as per our Ayurveda treatment modalities, the diagnostic method for the alcoholic liver disorders, that is first, the patient is very lean and thin, that is a cachexia with a fleshy look he has, and patient comes towards us with the abdominal distension, and we diagnose the patient as a Madatya as per our Ayurveda. Then we have do the underline the line of treatment as per our Ayurveda. That is first Charakacharya told about the Ayurveda treatment for Madatya. The first is a Nityameva Virechana. Means the daily we have to give the purgative medicines. For what? The ascitic fluid which is accumulated in the abdomen, we have to drain it, daily drain it. Then the osmotic pressure is released and the ascitic fluid remains, slowly decreases day by day. For that, we have to give Nityameva Virechana with, we have given Erenda Snehapana, 30 ml in the morning. With the Shunthi Kata. Shunthi means we all knows that is adrak. We have know that is the dry adraka means Shunthi, Vishwa Bheshaja, that is given with the Erenda Sneha, and that is given to the patient in the morning. After that, patient have a 3 to 4 Virechana Vegas will come and reduces the ascitic fluid slowly within a 3 to 5 days. And daily we have taken the girth of the patients, and the next line of treatment is Erenda Patra Pattavandanam. Means we have to reduce the sthanika accumulation of the ascitic fluid. We have to stop that with that therapy. Means if you have Akasha Mahabhuta, which is a gradually increases in ascitic patient, we have to reduce that with binding the patient with the Erenda Patta Bandhana. Then we have to give the patient that is a Arogya Vardhini, which is a medicine for the liver disorders elaborated by our Acharya. The dose for the Ayurveda Arogya Vardhini is a 250 milligram before meal, means in a apana kale, means before meal means when the stomach is empty, that time we have to give 250 milligram of Arogya Vardhini in morning and evening, both time we have to give that medicine. Then the another medicine is a Kumari Asava. Kumari Asava is the best medicine for the liver disorders, which is elaborated by our Charakacharya, and we have given the all patients of our Madatya patients in our Kaya Chikitsa ward, and now also the 2 to 3 patients are admitted in our ward of the alcoholic cirrhosis for the ascites, and we treat with this line of treatment day by day that patients have got very good results. The one patient I would like to share the experience of my one patient. He has having the bilirubin level which is 24 direct bilirubin, indirect bilirubin 18, and that patient is treated by all the gastroenterologists also in Mumbai, but the bilirubin level is not reduced. The cause is viral hepatitis. He has a causes viral hepatitis. He is not a alcoholic cirrhosis of liver. He has a cause viral hepatitis. But when he admitted in our Arogyashala Rugnalaya in ASS Ayurved Mahavidyalaya, then the patient comes here and she shows me the file. She has a big file, and then we treat with our Chikitsa Sutra of ascites. That is a Nityameva Virechana with a Tivrutta we have given him Nitya Tivrutta 20 gram daily for 10 days. And the bilirubin level from 24, it comes to the 4 within a 10 days, ma'am. This is a very excellent result we have got in the ascitic patient. But there are limitations also for the ascites also by these most of the causes. Some patients have got results, some patients have not because of their nutritional values and everything, and there is bull also. The all patients have not bull of giving the Virechana Nitya for 10 days or 15 days. That patients we have to treat with the combined therapy, means modern therapy and Ayurveda therapy. Both medicines we have to give. This is the limitation for the Ayurveda treatment. Sometimes we need allopathy treatment also for treating the patients of the ascites. Is there any questions, ma'am?
Is there any question for Ayurveda? Okay, so thank you so much, ma'am. Ma'am is guide to Anshul for his PG dissertation, and thank you so much for sharing your experience about treating liver cirrhosis. Thank you so much, ma'am. Please stay with us. Kamlesh Bagmar. He is assistant professor from Department of Surgery from Motiwala Homeopathic College, Nashik, and he is sharing his expert opinion regarding homeopathic approach.
Good afternoon, everyone. Am I audible?
Yes, sir. You are
Yeah,
audible.
yeah. So let us illuminate the knowledgeable session. I am really thankful to Dr. Gitanjali ma'am, Dr. Pratibha ma'am, as well as Dr. Sanjeevani ma'am, who could able to elaborately give the views regarding each aspect of what cirrhosis is. Now let us understand how homeopathy looks towards a person or a patient having a cirrhosis. So can I share my screen?
Yes, sir.
Yeah. Is screen visible?
Not yet, sir.
Now is screen visible, ma'am?
No, sir. Your screen is not visible yet. share your full screen, sir.
Yeah. Now?
Yeah, your screen is visible, but you have shared your full screen. So your slides are not visible yet. Till then, we have one suggestion from our just a second, sir. We have one suggestion from our Pro Vice Chancellor in chat box. It is for Ayurveda perspective of liver disease. Samprapti should be elaborated rather than treatment part. If sir is here, we may take his opinion. Sir?
Yeah, I will speak lastly because I think the.
Okay, sir. So, Dr. Kamlesh Bagmar, sir, please continue.
Yeah. Now, is screen visible?
Yes, sir.
Yeah. So we are talking about the cirrhosis of liver. Now, in each and every case, when we talk about the cirrhosis, the progress may vary, and the symptomatic to asymptomatic phases also may vary. And though we have been talking about that the serological parameters in the whole cases may differ, but the symptoms as per the individual also differs in a wide way, in a varied way. And this brings a homeopathy as a key focus, because when we talk about the liver cirrhosis, only alcohol consumption cannot bring on to a liver cirrhosis. Like when we talk about that every smoker doesn't lands up with a cancer lung, and in the similar way, every alcoholic doesn't land up into a cirrhosis. So as Dr. Pratibha ma'am has elaboratively talked about the various different types of cirrhosis from alcoholic to non-alcoholic, the morphological pattern in pathophysiology also do differ. What we talk about a micronodular, macronodular, or a mixed cirrhosis. So the thing what during the treatment management, how we consider is what are the factors which are contributing to formulate a disease in a specific person. So there are interplay of various factor. Now in this case, to be talked about specifically, the undernourishment is one of the key factor, along with alcohol addiction, along with as a laborer. So we can find it out that there are many factors in this person which is contributing and can giving rise to the development of a cirrhosis. That to a chronic alcoholism, chronic smoking are adding, along with the body's tendency or the susceptibility in homeopathy, how we can able to talk about it. Now again, when we talk about some emotional aspects which has been considered in homeopathy, like one thing which we talk about is territorial anger conflict. Usually the alcoholism is very well related with this territorial anger, where in your territory, if something which has been not getting managed, and at that time the issues related with anger or hatredness or irritation focuses on, that may going to affect a liver at the tissue of a liver and can cause such a kind of an pathophysiology. Apart from that, we are also having the drugs. Most of the time the people's consuming so many drugs which can land up into the liver injury. So overall, the interplay of all these factors, including genetics, including psychosomatic aspect, including autoimmune aspect, are being taken into consideration when we are thinking about a homeopathic perspective. So to diagnose, for a homeopathy, as to diagnose disease diagnosis, there is nothing different which is a difference which has been required. Like from signs and symptom on examination to the diagnostic investigations, whatever we talked about like CBC, LFT, USG are being taken into consideration. And ma'am has properly suggested, Pratibha ma'am, that there is no need of the biopsy as such in all these cases. But when we talk about the individual diagnosis in homeopathy, like Prakruti Nidan, what it refers to in Ayurveda, in the similar way, why this gentleman has to suffer with this illness? So we are having a holistic approach where individual as a whole is being considered along with his PQRS symptom, that is peculiar, cure, rare and strange symptoms if they are been there, apart from the disease, but the personality symptoms what we consider. The most key thing about the holistic science is to understand the mental as well as the physical quality of life, how it has been hampered by that illness, which are taken into consideration along with the accompanying symptoms, like in this case hepatosplenomegaly has been there, along with the three causes where homeopathy focuses on. One is predisposing cause, second is precipitating cause, and third is perpetuating cause. Now when we talk about a predisposing cause, there may be a hereditary history of maybe liver illness or alcoholism, where the genetics parts comes into a play, and where one can think of a homeopathically predisposing factor, and one can give anti-miasmatic medicines like medorinum is one of the very core, and thuja. These are the two core issues which have been coming up with the hypertrophied liver, apart from tuberculinum, where the fibrosis part is very important. The second is precipitating causes, like a person trying to consume an alcohol at a daily level. Is it his habit? Is it his financial or some problem which has allowed him to move ahead with the addiction? That also have been taken into consideration. And the maintaining cause, the throughout the years he has been consuming and smoking. So these three factors definitely play a role in the development of the disease, as well as in the management. We have to take care of all these three factors. So when we talk about the homeopathic perspective, it is having an holistic as well as individualistic perspective, where we can able to think about how the individual looks like a obese person with cirrhosis, the drug will differ rather than the lean thin person with the liver cirrhosis. So here we are talking about the personality traits. Apart from that, the underlying cause has to be understood and has to be treated with the gentle push to our own body's healing mechanism with the homeopathy, what we call it as vital force, which are being taken into consideration. So the way where the homeopathic perspective will going to have its key role is to understand PQRS or concomitant symptom, to get the key modalities. Like in this case, there may be an orthopnea, but which may be pathophysiologically common. But in some person of a liver cirrhosis who lies to prefer on abdomen, that may be a very peculiar modality or peculiar symptom, which will going to suggest his prakruti as well as medicine. In the similar way, what mental state or emotional state he has been carrying along with this disease, what kind of an constitution he has been having, the causation and the family history are being considered. So the approaches depend upon the pathology. Is the reversibility or irreversibility of the disease? Do we need to have a curative or palliative aspect? Is it a mild, moderate or severe ascites which I want to treat? Is the abstinence possible for that person? Is it the case with or without complication? So this is a complex consideration where we have to manage, we have to have our protocol while designing the approach towards such cases. Like rightly Dr. Anshul has suggested that this is the case of acute on chronic. So definitely when we have been treating, we have to think about in the homeopathy also, the acute management has to be treated. Later on, the chronic or the phasic drug can be thought of, where the anti-miasmatic drugs also plays a key role. But the key approach is the holistic treatment along with the dietary support, like what ma'am has suggested, low sodium and high rich protein diet. Alcoholic Anonymous Society, the one of the key factor where we can able to have a counseling as a family, as a unit, we have to consider. We have to help this person to bring him back from the habit what he is been carrying out. So overall, a supportive care and treatment has to be given. But when we talk specifically about the homeopathy do have a good number of drugs. While considering these drugs, the pathology of cirrhosis, if it is been accompanying with alcoholic, then we are having a fluoric acid. If it is a chronic, then we are having hedrahelix. If it is having a too much of dropsy, we can have apis, lycopodium, arsenic. If the indurated liver is been there, then one can think of graphites. So overall, the management will all going to depend upon what peculiar pathology, what peculiar symptoms, what peculiar modality the patient may be having. Specifically, when we have been talking about this case, I feel that this case where ascites has been very markedly been there, along with the pitting edema and along with the scanty urine. So one drug named apocyinum cannabinum is having its key action on the serous membrane and which can relieve the dropsical effusion by having a releasing the fluid retention. Apart from that, we are having some drugs like lycopodium, chelidonium when the jaundice is been present, markedly jaundice. Lycopodium when we are having a right-sided affinity along with the bloating and the gaseous distension is predominantly seen. Cardus marianus, one of the key drug with liver congestion, tenderness and hepatitis which has been there. Nux in drug alcohol abuse or in smokers with irritability as a key factor. Whereas phosphorus when we are having a fatty degeneration in the liver, bryonia where the things are being worse by the movement. So when we talk about limitation, yes, we do have in limitation when we have been talking about the complicated stages, when the advanced stages, even in the stages where we have been having an esophageal varices or if there are chances of bleeding. So we need to clamp all these things before the patient goes into a very deep seated state like a shock and hemorrhagic shock which he may land up into. Like coagulopathies, like one can think of if diagnostic or therapeutic paracentesis has been done, we have to take help of the other science as a supportive mechanism. And in short, when we have been talking about the upper level of 3, this is reversibility of cirrhosis when there is a stage 1 like steatosis to hepatitis stage is there. One can have a reversibility at this zone with the medicine, with the complete therapeutic management and the comprehensive care. But when the patient lands up with a cirrhosis, that too with a fibrotic, at that level, you will not find it out the reversibility which has been there. So at that level, when we have been having an irreversibility with macronodular cirrhosis, definitely we have a limitation, and at that time we have to take care of or take help of the other sciences. So that is what I feel is the homeopathic perspective, which talks about related with the cirrhosis of liver. And I'm thankful to all of you, those who have been attending and
Your
all.
slides are not moving, but you have covered all points we have given to you. Thank you so much, sir.
Okay.
Now we have Dr. Milind Nikum sir, Honorable Pro Vice Chancellor of Maharashtra University of Health Sciences, Nashik. He is here, and sir, please.
See, basically, I heard all the conversation of Anshul, then Sanjivani ma'am, then MPGI ma'am, also this homeopathy. Allopathy has elaborated all the things that how the cirrhosis has been occurred. Also, Kamlesh has also described that. But I want to describe how it occurs and how does it is calculated in Ayurveda. Because the treatment part, Sanjivani ma'am has given, but we don't require treatment here. How the process was occurred, and only Madatya is not only the cause of the cirrhosis. There are many reasons we can find out here. One is related with the Agni-mandya. If everybody agree that Agni-mandya is depend on the Pitta dosha. This Pitta is an whatever we can say the enzymes or the pancreatic juices. So this Pitta dosha is get disturbed Now, what happens and how it get affected? The Viruddhahar, that is the Nidan, that is the main reason why this cirrhosis occurs. So, Viruddhahar means what? Shita and Ushna Ahar. That is Atimatrasya, Atisnigdasya, Cha Akale, Cha Atimatrasya, Samashnatat. Uh, Means what? Whatever we eat in the morning and in the evening, that is, we can say that is about काय म्हणतात त्याला गरम पाणी नाही आहार आपण जो घेतो दॅट इज थंड आणि गरम म्हणजे जो नुकताच ताजा आहार ज्याला म्हणतो आपण that is the food we cooked immediately and we start to eat, that is different. And whatever the food we eat in the evening with the same food that is prepared in the morning, that is shila anna. So that is the main reason. Secondly, mausahar means non-veg along with milk. Those who are taking continuously is also a reason of this pitta dosha to get affected. Now, the samprapti occurs in such a way that udak and ambu has srotas. So that is an main samprapti where we find the thirst is the first reason in the ascitic patient, which can be elaborated in the symptoms. That is udak was srotas dushti. Now this udak get affected along with the ahar ras, which is the derived from whatever we are eating, the ahar, and from this ahar get affected. The amras is created in these things. Just to elaborate, in disease state like jwara, when we have a fever, our tongue is coated. This coated, and again it turns into the yellowish tinge. Now, this yellowish tinge suggested that it is an arm which has an bad odor also. So, this indicates that the whatever the food which we have taken is converted to arm, not the proper ahar rasa. This arm is now converted and get stuck to the intestine and also to the strotas, that is udakva strotas and ambuva strotas. Now, these strotas get blocked, and the reason the strotas, when it is blocked, the doshas are now accumulated in the twacha, and that is in the skin and the kukshi, that is the region where the ascites is developed. Now this ahar, that is amras, now get accumulated at the kukshi level, and now this kukshi get swollen, and then all the srotas get avruddha, and for that reason this cirrhosis gets started. The main reason is that inflammation of the liver tissue occurs, and along with the inflammation, that the pitta get affect with the rakta dhatu. This rakta dhatu get dushita, that is called as inflammation of the cells. Now this tissue get damaged and the scar is developed. So this is the reason where the biliary cirrhosis or alcoholic cirrhosis or necrotic cirrhosis occurs. So the main reason where the pitta dosha get affected, and which affects the rakta dhatu, which develops the scars. Now that becomes the yakrut vikaraha. So this is the main samprapti of the disease where we are going to discuss it. So there are many reasons for vikruti of the pitta dosha, where we can say that along with pitta, kledak kapha, and vat, which is pran, apan, and saman vat, is get affected here. So that is the main samprapti of the disease, where we can elaborate properly. And if we are to conquer this, first, I think the puddle sign has been missed in your all the four conversation, where the 500 ml and more than that, when the fluid is accumulated, the puddle sign get positive, which is the main first symptom, first sign that can be elaborated by the doctors. So I can conclude with this. Thank you.
Thank you so much, sir. Very well said. tongue is mirror of GIT, and sir told us about how to diagnose Vidagdha Pitta from coated tongue. Thank you so much, sir, for detailed thinking process according to Ayurveda while treating such kind of cases. So, any query from audience? If not, we can stop here. Thank you so much, sir, for your guidance. Thank you so much, Dr. Pratibha ma'am, Dr. Sanjeevani ma'am, Dr. Kamlesh sir, Dr. Anshul, and audience. Thank you so much.
Thank you.
You may share your feedback.